everyone, on behalf of Anand Bajaj Retina Institute of LV Prasad Eye Institute, Hyderabad, we present to you a novel technique for removal of extensive submacular hemorrhage. A 32-year-old male presented to our emergency services with chief complaints of diminution of vision in left eye since last one day after he met with a road traffic accident. Patient had also developed rib fracture, which was causing pneumothorax, hemothorax, and bilateral pleural effusion. The patient best corrected visual acuity was 20/20 in right eye and counting fingers in left eye. Examination revealed the presence of subconjunctival hemorrhage in the left eye. Posterior segment examination revealed the presence of vitreous hemorrhage and massive subretinal hemorrhage, which was extended beyond the temporal arcades. Axial horizontal scan showed relatively anechoic anterior segment and vitreous face with a hyperechoic lesion over the disc and temporal to the disc with low to medium reflective spikes, whereas axial vertical scan revealed medium to high membranous reflective spike with submembranous low reflective spikes, possibly suggestive of retinal detachment with subretinal hemorrhage. The conventional approach in such cases is the extensive retinectomy with manual removal of clot. However, the surgeon proceeded with an alternative approach. The surgeon proceeded with the core vitrectomy and removed the vitreous hemorrhage. PVD induction was done and vitrectomy was completed. Subsequently, the surgeon injected the 0.3 ml of subretinal TPA with 23 gauge soft tip cannula in superotemporal and inferonasal quadrant, causing the subretinal bleb formation. Thereby, surgeon waited for 20 minutes on the table for the liquefaction of clot and then aspirated the liquefied blood from retinotomy site. After aspiration of the blood, there was a large clot present in the superotemporal quadrant, which was manually mobilized with the soft tip to the retinotomy site. Hence, with the help of the cutter, the clot was aspirated with the cutter. Was done at the retinotomy site and silicone oil was injected. With our technique, patient gained the visual acuity of 20/80 after 1 month of surgery and 20/60 after silicone oil removal. In our technique, we could immediately aspirate the blood from small retinotomy site, and this was achieved due to clot liquefaction subsequent to the high dose of subretinal TPA injection compared to the conventional limited dose of 10 to 25 microgram. The highlights of our techniques are as follows. In our technique, we used a very high dose of subretinal TPA injection, that is 60 microgram, which is far more compared to the conventional limited dose of 10 to 25 microgram. A 23 soft gauge tip cannula was used instead of 41 gauge subretinal cannula to inject a large quantity of subretinal TPA. During the post-operative period, the visual recovery is achieved faster than any other technique, and there were no signs of toxicity on any of follow-up visit. We consider this technique superior to the technique of extensive retinectomy with the induction of retinal detachment to remove subretinal blood. The main limitation of the technique is the longer duration of surgery due to waiting period after injection of subretinal TPA. The contraindication of the surgery is similar to the systemic contraindication of recombinant tissue plasminogen activator, that is, if the patient had any previous history of stroke or myocardial infarction or any bleeding diathesis. The relative contraindication is if the time of presentation. If the patient present within less than 3 days or more than 3 weeks. In case of less than 3 days of presentation, there is a risk of rebleeding, whereas in late presentation of more than 3 weeks, subretinal TPA will not be of much benefit.